IAC extension, and also for lesions like acoustic neuromas. I mean, these are really the workhorse for CP retrosigmoid approach. And even this large compressive epidermoid tumor, the retrosigmoid approach readily gets us here and provides us adequate access to remove these types of lesions. However, we do reach some limits of the retrosigmoid approach, and there are some certain pathologies where I think there are some limits. And for my own practice, the vast majority of my posterior fossa skull-based lesions are largely treated by retrosigmoid, but there's about 5 to 10% where you have to use transpetrosal approaches. And I'd like to take this time to show you certain indications and what are the limits and what are the advantages, and also some technical nuances of using the transpetrosal approaches. So when we're dealing with a variety of petroclival and CP angle lesions, I think it's important that we have more than just one approach in our armamentarium. And knowledge of these other approaches and knowing when and how to use it can be a powerful tool in your armamentarium. Let's take, for example, this epidermal tumor. This was a tumor that you could see that was wrapped around the brainstem and lodged in front of the cerebellum. This tumor, I decided to choose to do a retrosigmoid, but I extended it to a far lateral because of this lower epidermoid component here. And you can see that it allowed us nice access to the tumor. You can see the cranial nerves, 9 and 10 and 7 here, but there was still a blind spot. I had trouble looking over the ridge of the cerebellum, and this was the residual tumor from the blind spot. And even with an endoscope, I could see it, but I had a difficult time reaching around the cerebellum to resect this part of the tumor. And so you could see at 9 months post-op, that residual tumor started to grow again. You could see it starting to get larger. And so I had to come back with a different approach. And if I used the same approach, I would be met with the same limitations. So as I thought about what approach would get me to this area and which approach can I visualize this area best, it would be an approach to look backwards on the brainstem. And if I can do that, that is best done through a Kawazi's anterior petrosal approach. So here you see a right-sided subtemporal exposure of the petrous apex. This is the borders of the middle fossa rhomboid, bordered by V3, GSP, and arcuate eminence in the medial petrous ridge. And I added a mini retrolabyrinthine petrosectomy so that I can get not only subtemporal access, but also this presigmoid access looking in this direction. And so this Kawazi's approach gives you this advantage of looking backwards on the brainstem, but it also allows you to open up Meckel's cave and get great short distance to Meckel's cave. Even though we don't need Meckel's cave for this approach, or for this case actually, I'll show you other cases where it is helpful. So here we are going subtemporal. We're looking backwards on the brainstem now. You see how we're now able to see in front of the cerebellum. Here is 7 and 8, and here's that tumor that we could not see in the retrosigmoid, and now we're able to remove it safely. And then we have a spectacular view of the basilar 7 and 8 and cranial nerve 6. And then looking upwards, we see the 4th and the 5th cranial nerves. And then here's the post-op scan. You can see we finally removed that area that was the blind spot, and to now achieve a complete removal. Here's a retrosigmoid approach I used for this petrotentorial meningioma. At first glance, you would say, well, this is just a simple retrosigmoid approach. But as I studied the films more carefully, you could see the highest portion of the tumor is right where the SCA and the 4th nerve will be juxtaposed to the tentorium. And I felt that this was going to be a limitation of the retrosigmoid approach, because unlike epidermoid tumors, meningiomas are a different animal. They're more adherent and they're not as suckable as epidermoid. And so we have to be ready for tumor in this area. So I went ahead and did a retrosigmoid approach, but I was prepared to have a plan B because I felt that the fourth nerve was going to be in danger from a purely retrosigmoid perspective. So I was prepared to go subtemporal, as you can see in my incision planning. So I'm just doing the retrosigmoid approach as usual. You can see we're devascularizing the tumor from the petrotentorial junction. And then there's the SCA vessel. Here's the fifth nerve that's coming into view. You can see the tumor is compressing the fifth nerve here. And then we're just debulking the tumor that's at the petrotentorial junction with an aspirator. And then this is the final deepest part of the tumor. You can see I'm having trouble safely visualizing the fourth nerve. So I did a subtemporal transtentorial approach here. You can see there's the fourth nerve coming into view. And there's the tumor that's right at the entrance of the fourth nerve where it's entering the tentorium. So this is the most dangerous part of the surgery. And you can see there's the retrosigmoid view. And that's the retrosigmoid view here. So you can see this resulted in a complete removal of the tumor. And the patient was neurologically intact. And I really wanted to get a curative removal on her for being a young patient. Here's another tumor. This was a smaller tumor, but this was growing. And the patient did not want to have radiation. So I went ahead and removed this. And I initially thought this is an anterior petrosal meningioma. You can see it's anterior to the IAC. I thought maybe a simple retrosigmoid approach would be adequate. But again, this is what I saw intra-op. You can see the tumor is in front of the seventh nerve. The tumor was firm. It was not very soft and suckable. And it was very challenging working with the tumor in front of the seventh nerve. This is the disadvantage. And even though I was able to get the tumor out, this patient was met with a facial palsy and also Iype stroke. So this approach was not so simple. And I feel that if I had done this through an anterior petrosal Kawasi's approach, I think I would have had a better result. So I think it's important that we maintain our transpetrous approaches, and we can divide the clivus into fourths. And then this is the general array of different approaches on how we approach various levels of the clivus. And let's not forget the retrosigmoid as well as the endonasal medial approaches to the clivus. So having all of these approaches in our armamentarium can really make you a versatile surgeon. We have to be like Michelangelo as he carved out these beautiful statues. These are the unfinished works that you can see in the museum in Florence. But this is a nice quote where every block of stone has a statue inside of it, and it is the task of the sculptor to discover it. I saw the angel in the marble and carved it until I set him free. And so when we work with the temporal bone, we have to be like archaeologists and Michelangelo, where we're uncovering these critical structures and setting the angels free so that we can get the routes of access to various parts of the clivus and the brainstem. And we like to break down the approaches into anterior petrosal and posterior petrosal. You can see the anterior petrosal is primarily a subtemporal route that gets you from middle fossa to posterior fossa. And the posterior petrosal route is mostly a retrolabyrinthine from sigmoid transmastoid corridor. So let's start with the anterior petrosal. You know, as we navigate this, we have to have this, what Roten used to say, the X-ray vision, to visualize these structures deep within the bone and to know the landmarks. And so that you can get this beautiful access to the brainstem between the fifth and the seventh nerves, and to also access the lower basilar artery. This is an example where I used the Kawasi's approach. This is a video we published some years ago. You can see this petroclival meningioma is medial to the fifth nerve, which defines a true petroclival meningioma. We did this through an anterior petrosal approach. You can see here we are dividing the middle meningeal artery. And after we divide it sharply, We'll start to peel the dura off of the dura propria from a posterior to anterior fashion to expose the GSPN. And then we'll peel the dura off of the lateral wall of the cavernous sinus. Is this interdural peeling between the dura propria and the periosteal layer of the dura. It's often adherent, so we have to use sharp dissection to lyse these adhesions. We then expose the petrous apex and the landmarks of the middle fossa rhomboid. We have an idea where that IAC is going to be by bisecting that angle at the geniculate ganglion. And then we mobilize the fifth nerve anteriorly to get the retrogasserian drilling, to get the true petrous apex that's hidden underneath the B3. And then once we finish the petrosectomy, we'll open the dura and expose the subtemporal component of the tumor. This tumor will be readily removed through your traditional debulking and then extracapsular dissection. And then we have to think about accessing the posterior fossa by dividing the tentorium. Here we've identified the fourth nerve. You can see the fourth nerve is situated here. We're going to cut the tentorium, but we have to first ligate the superior petrosal sinus. You can do this with clips, and I'm using a bipolar here. And then we open up the posterior fossa dura, so we have control above and below the tentoriums to finish the tentorial cut. And then you have to cut behind the fourth nerve. There's the fifth nerve coming into view. And if you follow the course of the fifth nerve and you go into the porus trigeminus, you can then open up Meckel's cave. Here's the tumor that's inside Meckel's cave right here. Now we're working in Meckel's cave, medial to the fifth nerve. Look how we're accessing the tumor that's medial to the fifth nerve. This is the major advantage of the anterior petrosal approach, is that you can have this working corridor working above and in front of the fifth nerve, whereas in the retrosigmoid approach, this tumor is ventral to the fifth nerve in the retrosigmoid approach and can be more difficult to access with the risk of more nerve manipulation. But you can see there's no touching of the nerve here. There's the basilar artery, and there's the final view. And the way I reconstruct these is I do a multi-layer reconstruction. I put a small duragen and then a small piece of fat. Make sure you do not overpack the dead space. That temporal lobe will re-expand quickly once the bone is replaced. And then here's a pericranial flap. So you don't want to overpack the temporal fossa. You're going to get mass effect and run into trouble with temporal herniation. So here's the post-op scan, a complete removal. And the patient was neurologically intact. Here's another case. This is a dumbbell trigeminal schwannoma going into Meckel's cave that you see here. And here again, we do a anterior petrosal approach, because this approach, like I said, is going to give you great access to Meckel's cave where that tumor is, and then also give you the CP angle component. So there's the final drilling of the Kawasi's approach. We're opening up the posterior fossa dura, the subtemporal dura, and then we're going to cut the tentorium to the free edge of the incisura. Make sure you cut it behind the fourth nerve. And then we're going to open up the porus trigeminus to get into Meckel's cave here. And now you'll see we have beautiful access to the tumor. And there's the posterior margin of the tumor. We're peeling it from what looks like the Iype vessels. And then we'll go ahead and start debulking the tumor with an ultrasonic aspirator. And then there's the seventh and eighth nerves right here. You can see we're working above 7 and 8 from this perspective. We're able to peel the tumor off the brainstem. And what we want to do is we want to preserve the fifth nerve and all the fascicles. There's the fifth nerve draped over the top of the tumor. And then here's a branch of the fifth nerve. Here's another branch. So we have to work in between these branches, paying attention to the tumor capsule, and then carefully dissecting the tumor from these fifth nerve fascicles. And the idea is to preserve as many of these fascicles as possible to prevent any facial dysesthesias. Here you can see there's the motor root, and then here's the sensory root. So the fifth nerve is nicely preserved. You can see this is a complete removal, and all you had was just minimal numbness in the B2 region. Here's a chordoma. You can see this is a purely intradural chordoma with fifth nerve invasion. If I had done a retrosigmoid approach, you could see there's a blind spot in the intrapedicular space. But coming in Kawasi's approach, you can now visualize this area in the intrapedicular fossa, and I was able to get near total removal here. This is another Meckel's cave tumor. I thought this was going to be a trigeminal schwannoma, but it actually turned out to be a Meckel's cave meningioma, a typical grade 2 meningioma. But look how I have complete access of this tumor. I have complete access of Meckel's cave. If I did this through a retrosigmoid RISA approach, a suprameatal transtubercle approach, I would be looking at the tumor in a very deep cavity, and I would not have this ability to peel the tumor directly out of Meckel's cave. And look how I can carefully separate this tumor from the nerve fascicles and get a nice complete removal of this tumor. Again, I have this excellent access and view of all these nerve fascicles, and I'm able to peel this tumor out. And there's the fifth nerve right into Meckel's cave. Meckel's cave is here, and a complete removal. So we can combine this with a posterior petrisectomy, and this is the combined petrosal approach, which gives you this multi-angle of attack. You can have a subtemporal and retrosigmoid working corridors. Again, multiple variable angles of attack and preserving the otic capsule to preserve hearing. This is an example. This is a trigeminal schwannoma. Again, a large cystic one entering Meckel's cave. You can see Meckel's cave component right here. We published this some years ago in the Red Journal that you can access. But here is the approach. We've done the drilling here, and we've done a combined anterior and retrolabyrinthine petrisectomy. We're able to preserve hearing because we're preserving the otic capsule. We cut the tentorium to the free edge of the incisura, and then this is the exposure that we can get. Here's the fifth nerve that you can see, and then the tumor is exposed in the presigmoid region. And schwannomas, these tend to be a little bit soft, and then we can start peeling it from the brainstem. And you can see the seventh nerve will be at the bottom here. Here we are peeling the tumor from the seventh and eighth nerves. And then we can have direct access to the brainstem. We're starting to peel the tumor from the brainstem off of the fifth nerve. And then following the fifth nerve up into Meckel's cave. So here's the subtemporal component. You saw that was the fourth nerve in the SCA, but now we're opening up Meckel's cave. There's the tumor going into Meckel's cave. There's the tumor that's medial to the fifth nerve. And then the most dangerous part is usually the most medial aspect, which is the basilar and the sixth nerve. Those are always the hardest to see. And then there's the final healing, and there's the basilar artery, abducens nerve. I left a little residual droplet of tumor on the sixth nerve to avoid injury, and a little bit of residual tumor that was left here on the seventh nerve. And then we'll do a dural reconstruction with fascia lata. We seal off the middle ear, we pack the area with fat, the mastoid dead space. Again, don't overpack the temporal fossa. You can result in compression. And this was a near total removal, but radiographically gross total. A very satisfactory result. Here's another giant trigeminal schwannoma, dumbbell shape that I removed recently. This was a combined petrosal approach, and the access to Meckel's cave was spectacular. I was able to get a complete removal using that approach. Now, just to comment on vascular lesions, these approaches are great for brainstem cavernomas, especially when they present between the fifth and the seventh nerves. This patient had multiple cranial nerve palsies from multiple hemorrhages. He had a failed retrosigmoid approach by another surgeon. They also tried to do this endonasally, transclival, and they were still left with residual. There's a DVA. It's important to preserve the DVA when you're doing these approaches. And so here we are drilling the combined petrosal. This is the retrolabyrinthine portion. There's the otic capsule. We'll then open up the dura. And then there's the fifth nerve. There's the cavernoma just below the fifth nerve. And then we just remove the cavernoma in a piecemeal fashion, carefully dissecting it from the brainstem. And then there's another portion of cavernoma that was hidden above and below the fifth nerve. So we're able to do this and work above and below. There's usually a lot of scar tissue here on these recurrent cases. And then we'll use an endoscope to look inside. There's the DVA. We have to preserve the DVA. There's the fourth nerve. And this was a nice complete removal. He's been recurrence free now for 5 or 6 years or so. And he recovered all his cranial nerve palsies. This is an AVM. This is a ruptured AVM. Look how it's deep in the cerebellum. And there's the draining vein here going into the Galen complex. The cerebellum is right at the quadrangular lobule. And where this is anatomically is in the deepest part of the cerebellum. And look how it's wrapped into the MCP here. So if we did this through a retrosigmoid approach, it's in the deepest part of the corridor, and you would have to either retract or resect this part of the cerebellum to get to this part of the deep AVM. And however, if we came at this as the combined petrosal approach, you could see I'm able to come in at a different angle. So this is the combined petrosal approach that I chose. And then there's the access to the AVM. Look how close the AVM is. I have beautiful access. I don't have to retract any cerebellum. And you can see I have easy access to the SCA early on to devascularize. You can also open up the horizontal petrosal fissure. This is the Iype feeder that I was able to take out early on. There's the basilar artery and lower cranial nerves. So I have great access through this approach, and we're able to devascularize this AVM. You can see there's the feeders. And then this is the top part of the AVM. This is the brains. The fifth nerve will be in this direction. And then carefully taking out each of the feeders here. And then once the AVM is largely devascularized, we can come around it circumferentially, come around the backside. And then once the AVM is completely devascularized, we will take it out in a piecemeal fashion and so forth. So here's the final view, and then the reconstruction with the fascia lata. And then I'm now using a cosmetic mastoidectomy. You can see we take off the mastoid plate, and then we can reconstruct it nicely, and then put some cement to get a beautiful reconstruction. So here's the post-op angiogram, a good resection of the AVM. This is a large epidermoid tumor. You can see it's involved in, it's wrapped around the brainstem here. So I didn't want to make the same mistake as before of a pure retrosigmoid approach. So we're going to do this through not only a retrosigmoid, but we're going to come at it, this portion for a combined petrosal to have triple avenues to the tumor. You can see here is the combined petrosal approach. And here's the portion going subtemporal. We're able to get this portion of the tumor. And why this approach is advantageous, you'll see in a moment, is that the cerebellum is here. This is the front of the cerebellum. And you can see, I can look in on the anterior surface of the cerebellum very easily and peel off these very adherent tumor capsule from the front of the cerebellum. And this is the blind spot that you do not see with a retrosigmoid approach. And now we're going to come in through the retrosigmoid corridor to get the rest of this tumor. So here's the retrosigmoid corridor. you can see you have to carefully dissect these small capsules off the nerves and neurovascular structures. There's the Iype perforators, but you have to leave a little bit of remnant on these critical structures because it's very adherent. And so here's the final view. Here's the seventh and eighth nerves, lower cranial nerve, sixth nerve down here, and a beautiful, spectacular view. And this was a near total removal of the tumor. And then lastly, the challenging pathology that we always treat or consider treating on these approaches is the petroclival meningioma. These tumors are often treacherous because they encase the basilar, invade the cavernous sinus, and they're cobblestoning. Pay attention to cobblestoning of the tumor. This usually means there's peel evasion of the brainstem surface. So you have to leave a microscopic residue on that interface so you avoid any brainstem strokes. But we can do variations in these petrosectomies by doing a transcrusal approach by removing the superior and posterior canals to get better access. And if the hearing is completely gone, you could do a translab. And then in rare cases, we rarely do the transcochlear variant. But here's an example where we do the transcrusal approach for this large tumor. I think this tumor was better approached through combined petrosal as opposed to a retrosigmoid. Look at how much compression there is medially. And so to do this transcrusal approach, you have to drill off the superior and posterior canals, but you have to plug the ampulated arms of the semicircular canals. So here is the drilling of the transcrusal. You'll see that we use copious irrigation to flood the field. And then we'll wax off the ampulated ends of the semicircular canals. And then by doing this, now we can drill off the common crus. And look how much access we have to the petrous apex. By getting rid of that superior semicircular canal, you have a bigger subtemporal window. And then we'll go ahead and incise the dura, peptic centurium. There's the lower cranial nerves. And then we'll start working on the tumor, which is going to be just superior to the fifth nerve. And then we can peel the tumor off of the fifth nerve here. Here's the fifth nerve being pushed downwards. There's the brainstem being separating the tumor from the brainstem and the fifth nerve. There's the exposure of the basilar artery, and then we'll open up Meckel's cave as we did before, taking out the tumor that's in Meckel's cave. And then the last part of the surgery is usually the most difficult. It's the area around the fourth nerve. Here the tumor is very adherent to the fourth nerve. There's the sixth nerve anteriorly as well. Oh. And then here's the last component of the tumor. Here we're sharply dissecting it off of the brainstem, the critical structures. Lysing, you don't want to pull, you want to use sharp dissection and lyse the tumor from the arachnoid adhesions. And here's the final view, beautiful view of the cranial nerves. I often use the endoscope, like I mentioned, to get a beautiful view of the sixth nerve, Meckel's cave, and so forth. So this was a radical near total. I left a small, tiny adherence to the trigeminal rootlets, but I was able to preserve the hearing in this transcrusal variant. So in conclusion, you can tailor these approaches, and I think it's a useful tool in our armamentarium, and it can provide a significant advantage, especially going in front of the brainstem and in front of the cranial nerves. And it can be a powerful tool when you use it in appropriate cases. Thank you again, and I appreciate this opportunity. I'd be happy to take any questions.
Thank you so much, Dr. James. Do you have any questions from the audience? Yes. Hello. Are you able to listen to me?
Yes, I can hear you.
Yeah. When you do these procedures, how much is the time duration? Do you
stage the procedure in don't stage, don't work on one level, but do rework on the same patient and see how do you do it as a continuous process.
Yeah, thank you for that question. Very important question. So I can tell you, when I first started doing this, I was working with my ENT neurotologist and you know, I made the rookie error where he was done with the bone work late in the afternoon, maybe like 4 p.m. And I was opening the dura after 4 p.m. and working on these tumors from, you know, 6 p.m. to past midnight. And then I switched to staging it, where we would stage the procedure one day and do the tumor removal the second day. But you know, as I developed more experience, I developed more comfort in doing the drilling. I became very fast at doing my own drilling. I studied the temporal bone, you know, in the lab myself, and I studied, you know, various surgeons. So now I do my own drilling, and I'm actually faster at it. So I can start removing the tumor at 1 o'clock. So now I do it in a single day, because for me it saves time. But I think you have to do it based on your experience. So certainly if you're just starting out and if you're working with an otologist, maybe you want to stage these. And then as you develop more experience, you become faster, more efficient at the drilling or the tumor removal, then maybe you can do single stage. But I think if you're starting out, maybe you want to consider staging it.
Thank you so much, Dr. James. That was a fantastic talk. Can you hear us, Dr. James?
Yeah, thank you very much.
Thank you so much. Our last speaker is Dr. Vikas, who's professor and unit head of neurosurgery from Robotics. He will be speaking on transcavernous approaches to brainstem tumors.
Friends, last talk, 2 days of hectic. I think we have covered long way which has been covered. Anything to have made with very controversial topic. Because the explanation applicable to the fact. So that should bring that's a very difficult. There are some centers that so this is a right side. This so this is the corridor which you access, which you get at the end of the complete transfer. Incidentally, accurate transfer. Which was the mid-range level. So as you can see, this spite of this approach, there are a lot of structures. The corridor is very narrow. There are 54 structures in Temple, and as yet we are not able to see the unit of structure. That's a big problem with this situation. So brainstem is a pain to focus. And there are simply so many things which will be working. It is actually justified. So each one of them is operated on top. So that's however is available there. So electric application reaching finally. The corridor is so narrow. Kind of the best resection you can get away with this. And what looks pretty simple on the images that it is different. Becomes complicated because there is this last one corporator. What do you do? You abandon after doing all this. So this is the problem with the distributions. So this is the maximum exposure you can fiction what is apparently a very morbid but move the development this moment led to another moment. But we can see that at the end of it, we have clear visualization all the way to half of the picture. How about this? Makes that plan, then operate, not to operate itself as a partner. Even if you decide to operate, you have to ensure that the morbidity of your physical is not existing. So what the transferable network actually does is it combines, like talking to you with the previous it combines a lot of it gives you approach gives you access in this blue region. So that's a very expensive which is it is not something that you get with any other single approach. As you've seen in the previous presentation, we need to do multiple corridors to get the same amount of approach which you can actually get with one single exposure, one single neural exposure can be very sensitive. What we can transfer of approach can be shown by the everything inside of the brain is taken out from the natural benefit. So you take out the entire spectrum load with the neuron outside. So that you have a corridor of that extent, which is all the way from any part of this brainstem. So, this is it's a repetition. So it's a period of you can do an orbital. This is also applied in different from the Terraverse. Again, I emphasized this yesterday. What's part of the procedure? This thing is all about the code, the landmark, the flag, the identify the DSP. Most of the other features that confidence of as a measurement will as I shown yesterday, the entire article is exposed. No, you just don't go there and expose, identify, collaborate, and touch. What that does is mobilize the control data on recurring attachments of the sample data to the second step is in the camera center. So graduation of the what is followed later is the giving of the superior orbit. That's a key thing because it gives you a mechanical. So that step ensures that you get this clear plane. So major orbital band is something which is almost considered difficult. It's always described very difficult to identify and it is lucky to identify. Once you get that one, ensures that you do not have to organically associate with this transfer. So that's the reason it is emphasized and so on again. Once you get the video incision or raising application, you are the question and feedback, you are reflection, relative using. So again, next step is one of the answer. What do you want that? On which we diagram is this and then so doing the same steps. So this is the orbital picture. Left side. So you cut between the orbit over here. So this exposure is once you're done that, you can actually make out the clearly make out the once you're done that, you can reach up to the medial part of you. So when you export between the part and the famous genre and the either of that was something of that sort happens. Just to see the issue of the brand, any variety, we are into the genre side, we stop as you can see. Training actually becomes very easy as you can see. Once you run the equation, because the computer will definitely run and you want and you can sure that you can fill it out. Next time, utilization is parallel to the unsaturated the basic idea is to avoid the student. That's something that the key step here is that this in fact you don't have to be examine so that mobilization is called the third round and the fourth round. Now, after you finish all of this, but it's still not complete. So, hopefully, you have to analyze this. Yesterday, the section I demonstrated there. And once you do that, you have to actually define the level. So, that completes the full mobilization. Stepwise, the second picture, goes all the way medial to the SCA origin, like this, so that deep structure will not here. Somewhere near the exponent, turn backwards, but towards the extreme of the complete. So this is at the metal strip. Similar procedure at the metal strip, that is cutting of the dura on top of the metal strip. Yesterday, not the dura on top of the metal strip. Cutting of the dura over the metal strip. What is seen here? So this completes the legal expression. Key corridors, this is the descendant ganglia, the whole structure is now have to mobilize the dura from so lateral and features here is the pictorial at the center of the thing is so friends and mentioned that with one picture show, patient comes rapidly deteriorate, the kind of lesion, acceptable, as soon as the company outside which is some part of it.
حبيبي روح الامارات غير طرايقك لا روح
Friends and
الكويت
mentioned
روح
that
البحرين
with one picture show,
تأشيرتك موجودة
so orbital the gamma to provide superior orbital pressure. So we utilize that simple piece of bone to get the superior orbital pressure. Correctly explain so the view of the optimal position. Second sharp resection over by both sharp resection. The plane is obvious. It cannot be very obvious from the video, but it is very obvious when you actually do that. So once that is complete, we can, yeah, so this is the mobilization of the flying. So the entire normal of the is not given, it is not deep. You start seeing of the various relief of the end of the final. Currently, this spinal is performed in the final. So, resident performs spinal that forms unlocking it unlocks that key corridor into the key corridor. That's the thing of it. So you can actually pass so the next step is you have to do the utilization. Completion. So this is the part that white spot to get in the diagram. So faster revision. At the completion of your dissection, you will see kind of further development. So just in the section, as shown yesterday, when you can use cases, you can see the stage, but you are not very confident that the late stage just an exposure like that, explained yesterday. So it is necessary to actually get SPL towards the base, so that the
We have good evening or good morning from Miami Beach. We start in about 5 to 10 minutes. And welcome everybody. Good evening, good morning, everybody from Miami. I'm gonna change the background. Yes, we are starting soon. Takashi, how are you doing?
Yeah, I'm fine. I'm working for the night shift, but and I try to change the background neurosurgical TV.
Oh, okay.
Yeah, I try to
You had it before, right? I saw it. I
yes,
think I saw it
Kyoto's
before.
picture. Kyoto's picture, but it's not available these days. So I try to add.
So go, okay, let me just explain how you do it, okay?
Mm.
Open the menu. Can you open the menu next to the camera, right?
Okay.
Open the menu.
Open the menu.
Yeah, you see the camera at the bottom, with next to it is a menu
Menu.
for video, yeah.
Video.
The bottom left, there's two icons. One's a microphone, one's a
Yeah.
camera. If you
Okay.
open the icon of the next to the video, you see that little hash mark?
Video. This bar. Okay. And virtual background.
Yeah, there you go. It says choose virtual background.
Virtual background. Okay.
Okay,
And
open that, and you're gonna see, this is kind of hidden. You see the plus?
plus.
Yeah, I know we're
Okay.
echoing, we'll take care of it. You see the plus?
Yeah. Plus.
Click on that. That opens up your computer. You can pick any image you want.
Okay. And I try to find the
You want, oh, you got it. You understand the principle. You got it.
yes.
Takashi, why don't you introduce Iype, okay?
Yeah. And I try to
You're now officially working for Neurosurgical TV.
yeah. Option working.
Please don't have any accidents.
Okay. I try to take a Kyoto picture.
Yeah, there's an
But
echo. I
I cannot
know.
find
Thanks
it.
for telling me too.
And
Because
also
basically,
you can send a neurosurgical TV icon only, so I will add it.
okay, you want me to send you the icon? Okay.
Yeah.
Let me get some things. Is that echo still there?
Yeah. This was
There was an echo. Is there still an echo?
okay. So yeah, the Kyoto's picture. So I try to looking for the
Okay, you still hear echo, Ryan?
Kyoto's picture.
Still, huh? Okay, that means one of us has
Oh,
a another like a YouTube channel open to the webcast, which some people do. They watch
okay.
both. So Takashi, check on your computer. Make sure you're not on YouTube.
Okay.
Also, in addition to this, it's not. I closed all my windows, so sometimes I'm the culprit.
Okay.
Oh, okay. Hi. How you doing, Raja? Just a few minutes. You came a little late. We'll talk later, okay?
Yeah. Okay.
I'm talking to the Raja. No, Doctor, let me talk to Raja quick, okay?
Okay.
Raja, you're gonna do a presentation of like a demo of the product after the webcast? Can you chat or tell me? You can unmute and tell me if you'd like. Do you hear an echo, Takashi? Or you have video of the product? Okay, you're gonna introduce the video, right? I'm gonna introduce you, and then you're gonna introduce the video, okay? Is that okay, Raja? Can you speak to me now? You can speak to me now, yeah. You're not muted.
Mute. I try to put the Neurosurgery TV icons, so I want to.
Okay, let me send it to you.
Okay,
We have a few minutes.
okay.
Let me see here. This is like anesthesia. Everything's really quiet and dull. Then you come down to the wire and things go crazy.
Oh, okay. This is
No, I mean this is not bad. Let me see where it is here.
Mm.
Okay, here we go. You're gonna put it.
Okay.
Okay, that's the icon. I could have a better resolution, but
Okay.
I don't.
Put this.
Oh, and Raja, don't worry. We're not going to record the until you're a little more experienced. We're not going to record the commercial. When I end the webcast, I'm going to end it on YouTube. However, we'll keep the Zoom going, so it's a private webcast. Do you know what I'm
Yeah.
saying? Do you know what I'm saying, Raja?
Is it?
Are you muted your voice? Let me get your voice because I want to talk to you. Okay, you weren't even allowed to talk there. I'm sorry about that.
Hello, Mr. John.
Hello, Raja. How you doing?
Yeah, I'm good. How about you?
Good, very good. Don't worry, we'll take it slow. First of all, I'm going to end the webcast. So after the webcast, you stay there and everyone's going to stay here. So it'll be a
Yes.
private Zoom. Do you know what I mean?
Yes, I got it.
Yeah, it won't be on YouTube. So don't worry. You know, no one's going to see it really, except for the panelists. But it's a good time for you to practice,
Yes.
how to handle it. I don't know how much experience you got, but uh, I'll just lead you. I'll just say, hey, Roger, how you doing? Could you and introduce you, and then you say, okay, I'd like to. Nice to meet you. I'd like to show you a demo of a product we have featured.
Oh, sure. Oh,
Because
sure.
we want to bring the advertisers into the experience because they're always were part of the experience. They weren't just lectures. No, there were conventions with advertisers. They've supported medical education throughout the years. And this is a way for them to advertise with online webinars. They're gonna do nothing but increase. Okay, we'll talk later. Hey, I guess Iype will be in a second. Let me just. He likes to make a grand entrance. Well, I tell you what, Roger, why don't you ask ask your boss if you want it to be live and you want it to be seen. In other words, stay on your YouTube for your presentation, okay? Okay, Raja?
Confirm with my boss, doc.
Okay, well, your audio is not that good. Can you
Yeah, Mr.
talk?
John.
Can you,
Yeah,
is your
yeah, Mr. John.
is your audio okay?
I think it's good. Is it audible?
Okay, I think it's okay.
Yeah, Mr. John. I will ask my boss to confirm things to telecast and YouTube also.
Okay, someone has their YouTube open. Okay, please check. It has been brought to my attention by Ryan, which I appreciate. So please check that you don't have your YouTube because we're getting an echo. Do you hear an echo? Does anybody hear an echo? Hello, guys. I need some feedback. We're not recording. Does anybody hear an echo? I don't, but does anybody hear me? Takashi?
Hear you.
Oh, okay. You hear me? Okay.
I can hear you. I can hear you.
Okay. Do you hear an echo, Takashi?
Neko, icon,
Echo. Echo.
echo,
Do you know what echo is? Does anybody else hear an echo?
Neko.
No echo. Okay.
No echo,
Good.
no echo.
Okay. Uday said, okay. Thanks, Uday. We're waiting, right, Iype's arrival. He should be here in a second. I just chatted with him.
Mm.
Okay, we're waiting. Don't want to tell him again.
Oh.
So how are things in Japan, Takashi?
It became this is a big holidays.
Oh, today?
Yeah,
Okay, I
10-day
checked.
holiday. We call April 27th to March May 6th. The 10 days holiday.
Okay. Okay,
But
Iype has
it's
arrived. I'm sorry. I'm sorry to interrupt.
okay.
So today's out. So the hospital is like holiday time, huh?
Yeah, holiday time. But I'm still on the night shift. Still working.
Oh, okay.
Yeah,
So you're not at the hospital.
now in the hospital.
Oh, you're now in the hospital.
Now in the hospital.
Oh, okay. You have good connections there, right? Internet
Yeah,
connection?
yeah. Good evening, Iype.
Hey, I. Can you hear me? You're
Yeah.
muted.
Picture.
Can you hear me?
Yeah, I can hear you. Can you hear me, John?
Yeah, Ike, you're coming to Miami.
I'm coming to Miami, man.
Wow,
So
that's great. That's February, right?
yeah, Jack Marcos is organizing a meeting next year.
Oh,
The WSBS, the World Skull Base, and
Wow.
also
Even though he's in Houston, even though he's in Texas, he's organizing it in Miami, huh?
yeah, no, Jack Marcos, I thought is in Miami, man.
No, I thought he took a position in Texas.
Oh,
Well, I think the World Skull Base meeting is in Miami, if I'm not mistaken.
Okay,
mhm.
okay.
Miami.
I thought I'm pretty sure IP went to Houston or a big program out there about a month ago, 2 months ago.
Let me just see Jack Marcos because he wrote to me and
Check is, well, check later, IP. Let's start now, okay?
no, man, it's in New Orleans, Louisiana.
Louisiana.
Okay.
It's in Louisiana, New Orleans, Louisiana.
Oh,
So no, maybe I may not be coming to Miami.
Okay, hold on. Let me see.
I'll be coming for that one.
Oh, okay.
okay.
We got some interesting things to present now. We're doing a lot of things with AI in neurosurgery. So we're trying to project the output of the exoscope into Apple Play, and then use the VR Phantom of a scan to tether into that. So we're working with a company called Medivis. So we probably are getting the software in our center. So
Well, that sounds good.
World Skullbase will have some interesting things to talk about. When do you want me to start, John?
Hold on, I gotta put this on the internet now. I'm moving code around. Sometimes I forget and we start and we leave it just on Zoom. But we want to put it on YouTube so people can see it that aren't in the panel. Just 1 second. Okay, I 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett broadcasting from sunny Miami. It's early here in the morning. We have another neurosurgery innovations with Iype Cherian, well-known Indian neurosurgical educator, and we'll let Iype handle the show. Go ahead, Iype. It's all yours.
Yeah, so thank you, John. Here, what we wanted to talk about was the art of ultra microneurosurgery. Now, we know that the microneurosurgery started with the Assaghil's era, with the introduction of microscope. The microscope usual zooms are up to 25, although most of the neurosurgeons don't use that kind of zoom. Except for the Japanese who use very high zoom, and my friend Yuha who uses very high zoom. I haven't seen many people using that kind of zoom. So I'm going to share my screen and start off straight away. Can you see my screen?
Hold on, Iype. Yes.
Yeah, so you can see my screen, right?
Yes, perfect.
Yeah, so our quest for ultra micro ultra microneurosurgery started way back in 2015. And we were thinking maybe the Zoom is not enough. So what we did is when we moved to a new place, the Pentiro that we had, we wanted to reverse engineer it for 40 Zoom. So what we did was we got a ProMag Iypes from Zeiss, and that was not doing the whole, that was not getting us 40 Zoom. So we put a 3-step magnification changer onto the new Pentiro. I mean, imagine we had a 3D head also. We had a 3D head, we had ProMag Iypes, and then we got from an old microscope, we sourced a 3-step magnification changer and put it onto the Pentiro, and it screwed the entire balance. So we had to send it back to Zeiss so that they could rebalance it. They rebalanced it and sent it to me, and probably that was the only Pentiro that Zeiss had manufactured with a 40 zoom. So, and when I got the Kinevo, as after I joined here in India, Zeiss, the top guys called me up and said, "Oh, presumably you want the same thing in this Kinevo also." So we said yes, and they got it done for us. So the Kinevo also has a 40 zoom. Now the thing is, I was not happy even with that. So I was looking at the Mitaka microscope that the plastic surgeons were using, and they were talking about 80 zoom, and that's when we came across the S-Collapse exoscope, which had 80 zoom and excellent. I mean, they said 100 zoom, but 100 was without the stereo depth. You were having loss of stereo depth with 100 zoom, but 80 zoom were having excellent stereo depth. So first, to put you into perspective, exoscope is something that we started working on from 2017 onwards. So this is one of the first exoscopes that we made. This is an exoscope with a universal robot arm, 2 arms with an exoscope and a webcam. And what it is doing is it can do a pattern recognition and centralize the image. That's what it's doing. It will look for the mark, it will scan the image, and when it sees that pattern, it will centralize it. You can see the mark there. It will centralize it now. So I don't think any exoscopes even right now can do it. So this was our work with a shoestring budget, with literally no budget at all. But we could do it with an engineer from Spain. And after that, this is with head movements, the robot will move. See. Again, this was our work with the same shoestring budget, but I cannot see it happening. BHS scopes, they do this. That was because I was working with them. Till Lars was the CEO of BHS scopes. I was working with them and they adopted this principle. But I don't know, after that, they went rogue and I mean, they were not listening to what we were saying. They manufactured some scope. I don't know how it is. And I haven't seen one of that in neurosurgery. So, well, talking about exoscopes and endoscopes together, we wanted to show you something more. And this is an exoscope image. And this is a 3D endoscope image. This is a laparoscopic camera. It's a 10 millimeter scope, but it is not good for a transnasal or transventricular endoscopy. But for cranial assist, this is one of the best scopes because the clarity is just, you know, it's 4K. It's really 4K. And you can see on the exoscope, you can see this endoscope there. And on the endoscope, it's a 30-degree scope. So I can beautifully, in 3D, I can see the image and I am able to take the tumor out from the parasagittal region behind the tent, behind the fox. This is the robotic endoscopic holder that we have designed for this scope, cranial assist, and this can also work for transnasal, transventricular, everything. So you can see it's got 7 degrees of freedom, and this is with Sanma, an Indian company. And I must say, I must commend that they have done an excellent job. We used to have the Mitaka holder before, the poinsettia arm, pneumatic, but I can say that this is far better. And this is the exoscope that we have designed with Sanma. This is called the Sanma Yoko, after Professor Yoko Kato, who happens to be my daughter's godmother, and my daughter also the same namesake. So this is the Sanma Yoko first generation exoscope, because we wanted the shift from the microscope to be smoother. So this is just like a microscope, but with no eyepiece. So it has electromagnetic brakes, and you can adjust it anywhere you want. And the camera is as good as the EOS exoscope with a 100 zoom. And this is how we work in the lab and in the theater with the exoscopes. And this was our innovations chapter. We talked about the hyperscope. So the hyperscope is a very high magnification with augmented reality and AI. Incorporated into the exoscope. So this is our work, ongoing work. This is showing how a VR image of an aneurysm is superimposed exactly onto the aneurysm. And this is our textbook chapter. So this is exactly what we do right now. This is our intraoperative CT scan, 192 slice scan, which comes into my OT and takes a scan, and then we are reconstructing it in medical holodeck, and taking the VR phantom, and I have a sterile mouse with which I can superimpose onto my patient's head, and then I can see where the aneurysms are, and I can play around with it. So this is the intraoperative suite. And this is a scan which is superimposed onto a patient. And we start with ultra micro neurosurgery with one example from the microscope first. So you can see this is a paraclinoid aneurysm. It is actually transitional, really transitional, because part of it is in the cavernous sinus. This is the clinoid, and that is the aneurysm. And what we are going to do is we're going to take off this clinoid and then cut the distal dural ring, and then so you see the zoom. This is with the Pentiro with 40 zoom. So I am doing a pericavernous dissection. We described this technique in 2018. We were talking about it way earlier than that, from 2012 onwards, but we published this in 2018. And you can see how this is the cavernous sinus. This is the clinoid. Clinoid is being taken out. So the aneurysm, that is the optic nerve roof. It is drilled out. And this is the clinoid, and that is where the aneurysm is. And that's the aneurysm. So when we are drilling, you can see the aneurysm through the bone. And we are using a 0.75 millimeter drill now. Drill off the entire clinoid extradurally just over the aneurysm. The dura is protecting the drill from touching the aneurysm. So in this case, having a dural breach would be not good. So using the 0.75 millimeter drill, First to 2 millimeter drill, then 1 millimeter, and then a 0.75 millimeter drill. Under very high zoom. You can see that the optic nerve is here, it's massive. So this is near 40 zoom. And once we have taken off the optic strut and everything extradurally, see, now the aneurysm is clear. You can see the blackish color of the aneurysm there. That's the optic nerve lateral margin. And then once we open, it becomes very simple for us. So that is the aneurysm. This is, if you have not done this bone work, it's just impossible to be easy about it. Then you'll have to, what other people generally do is they open like that, and then they drill the clinoid intradurally, and then they try to clip. But here, there is no clinoid at all. Everything is taken out. That's optic nerve, and that's aneurysm. So I'm going to cut. Now I'm cutting the falciform ligament and then coming over to the distal dural ring. I have cut the distal dural ring and also the proximal part of the proximal dural ring, and I can get a very clear view to the aneurysm now, and I am going to clip it now. So you will see once I have cut the, I have shaped the proximal dural ring. Now I can see directly into the cavernous sinus. So there would be some bleeding, and you can stop it with the glue that we make it in-house using gel form, fibrillar Surgicel, and the patient's serum. So we make this glue, and it is extremely very good for arresting the cavernous sinus bleeds. So we keep this. We are going to put the clip now. And that is a carotid aneurysm line. And you put a straight clip. And when you put the straight clip, you can see the carotid. Medially, you can see the cavernous carotid. That is the C3 carotid, paracellar carotid. That's the proximal dural ring. The distal dural ring is cut here. That's the proximal dural ring cut, and it's we are going into the cavernous sinus with the clip. That's a cavernous, vertical cavernous carotid. That's a vertical cavernous carotid. That's a cavernous sinus. Okay, the sixth nerve is posterior there. Okay, there's a small dog here. We can handle that with another small clip or big clip, and just clip just enough. Yeah, so that's the vertical carotid, and done. There's another case which we want to show. There's a cavernous sinus meningioma, very vascular and very hard. So we wanted to show you with ultra micro neurosurgery what is possible. So we are using an exoscope now with low zoom, and then once we come into the orbitomeningeal band, we are going to zoom up. Once we do the cavernous peeling, you see the tumor superficial to the temporal lobe. Remove all that, and then you will see the cavernous sinus. And that's a cavernous sinus there. That's the fourth nerve, V1 and V2. You can see the nerves at such high magnification. And that's the clinoid process. That's the clinoid process. This is the third nerve. And I'm cutting towards the, I'm releasing the optic or orbital roof. So using a 0.75 millimeter drill to drill out the clinoid process and the orbital roof, that's the third nerve. Taking off all that. Now you can see where the clinoid triangle is. That's second nerve, third nerve, fourth nerve, V1, V2, V3. All the tumor lateral to that is taken out. Then now we are going inside Parkinson's triangle. Opening that and then going into the Parkinson's triangle. You will see the sixth nerve very soon, medial to the V1 now. That's the sixth nerve, and that's a carotid projection there. The infralateral trunk will come over the sixth nerve, so one has to be very careful trying to bite off tumor from there. So, but very gently, you can keep on biting the tumor till that is empty. So you can go through different windows and keep on emptying the tumor out. Very high zoom, extremely high zoom. So this is the end result. Tumor can be taken out without any cranial nerve palsy. Cranial nerve palsy happens here only if you bipolar or if you are extremely rough with the nerves, but here no cranial nerve palsies. So cavernous sinus tumors cannot be taken out is not correct. Another one, again example of ultramicroneurosurgery. Well, this is a tumor that we have removed from the brainstem using endoscopy. So I don't think we'll discuss this. This is a tumor we removed using endoscopy. I wanted to show you there is a transclival approach, and this is the vertebral artery, this is the basilar artery, and this is a sixth nerve. So we went in through the windows between the vertebral artery, the basilar, the sixth nerve. We went in between those windows. And you will see all the structures here. That is the two vertebral arteries. And that's a clival dura, which is very vascular. And that's a sixth nerve, which is mobilized laterally. So the posterior petroclinoidal ligament and the petrosphenoidal ligament has been cut, and the sixth nerve has been mobilized laterally. And you are taking that is a basilar, and that is a perforator of the basilar, and the sixth nerve is completely mobilized laterally. And then you are taking tumor out between the two perforators, the vertebral and the sixth nerve. So complete tumor is out here. Post-op. That is the result. Now, there's another case where we're doing STMC for a giant cavernous aneurysm. And what I want you to see, this is really truly ultramicroneurosurgery. You see the vasa vasorum of the ST. Okay, where with the microscope can you see it? And we're going to anastomose it to M4, not even M3, M4 vessels. So very small vessels, but you can do a beautiful job with the exoscope. You can see it's far away from the sylvia. So yeah, so this is again, the zoom is near 40, 12 sutures, 5 on each side, 2 sutures and toe and heel sutures, and then 5 sutures on each side. So 12 sutures in total, no leak at all. Anastomosis is complete. These anastomosis instruments are designed by us. It's from a company called Omedic, and it's Indian instruments, very cheap actually. The entire set is available for maybe $400 with 8 instruments, compared to the very costly anastomosis set we used to do before. And this is the result. We closed off the carotid trap, the aneurysm, and patient is, with permissions. another atrial aneurysm. I wanted to, what I want you to see is the magnification. See the magnification that we are dealing with. This is a fenestrated A1. So you see the vasa nervorum very clearly. Proximal sylvian being opened. A1 there. Interhemispheric fissure being opened. Identifying the aneurysm neck. That's the two fenestrated segments. That's the A2 going in there. So no need for any gyrus rectus resection. So dissecting towards aneurysm fundus. Once I see that, then I can put my clip in. Good clarity, and then the clip is in. Another pica aneurysm with an exoscope. So you can see that's a brainstem, that's a vert, that's a 9, 10, and the 11th going there. Accessory glossopharyngeal triangle. You can see, so the 9, 10 there and the 11 there. And so the same picture, you can see that's a vert. So dissections going on. You're taking this is a pseudo aneurysm part of that aneurysm being dissected. One second, I think, yeah, it's being dissected now. You can see this is a pseudo aneurysm. It's only one layer. So we dissect, and that's aneurysm now. That's a pseudo aneurysm part of it. So we take some time, and finally we're ready to put the clip. First, we use ceramic coated bipolar to just shrink the pseudoaneurysm part. Very risky, with no proximal control there. And now I can see this junction, so I can take off this arachnoid band and put the clip in. So once I take off that, and I can see the corner, and I put the clip so that I can see the corner, feel the aneurysm, and then I take the correct angle, and I go ahead and put the clip. Give me a second. Yeah, so that's another surgery. What we wanted to tell you is that our mind is the greatest lab there is, and you must learn imagination. Ultramicroneurosurgery, for ultramicroneurosurgery, you will have to shift. It is a complete shift. It's a paradigm shift. So, I mean, most of the guys I see, the young neurosurgeons I see from Africa, South America, and India, China, I mean, the Central Asia, they are not interested in using even the microscope. So it is a little bit of a comfort zone, you know, which you are losing when you're using the microscope. And when you're using the exoscope, you are losing even that comfort zone. You're going into very, very high levels of zoom. It is loss of comfort zone, but persist with it and it will change the way you do surgery. Thank you very much. This is the Asia's first exoscope. This is San Mayoko. This is San Masantuna. And this is our team. Thank you very much. God bless.
Well, thank you very much, Iype. Let me get my video off here. At any rate, great resolution. I'm still amazed at that resolution. It really is. I'm not a neurosurgeon, but that's very noticeable. So, okay, Takashi, how you doing? Do you have any comments for Iype's talk?
Yeah, thank you, Iype, for the nice presentation. So, if your technique, so the newer ultra micro neurosurgery, so the magnification will be higher and more clearly, so for the precise surgery, to contribute to precise surgery, amazing. So, this is contribute to the better result, the complete clipping, or some other micro microstructure of the small vessels. Is it contribute? I
Thank you. Thank you.
understand.
Yeah.
Thank you.
More
We also
comments?
started something called the total internal decompression. For most tumors, like for example, for a CP angle tumor, we take the arachnoid and then we never push nothing. So we keep on taking the tumor out till only the arachnoid is seen. So at very high zoom, we keep on taking tumor out with QSA or with the dissector, but the arachnoid is completely preserved. So most of the time we don't see facial or eighth, and because the vasa nervorum is not at all touched, we have a facial and eighth preservation rates which are very good. We call it total internal decompression.
Okay. Thank you.
Okay. Arshan, are you there?
Hi, John.
Hi, welcome.
Hello,
Hi,
Harsh.
Hi, how are you?
Absolutely good, Harsh.
Good demonstration once again. There is good to learn a lot about exoscope. We are not using, but yes, we are mentally gearing up to learn from you. And it's nice. So 40 times zoom is a really, small movement here and there looks very big. Even in
absolutely.
microscope, you have to get used to it, as you rightly said. Had a one query to ask you. When you are drilling with 0.75 drill, and I believe you are using a diamond drill to drill. So how long does it take to drill the clinoid?
That's a question. So I generally use the 2 mm on the lateral aspect where, I mean, sometimes I even use the biting on the lateral aspect. And only the medial aspect where after I've thinned out the clinoid, then only I use the 0.75. The 0.75, if I start drilling it with the clinoid the entire day, I'll be sitting down and drilling.
Exactly, I was really wondering. That's why I asked you.
Yeah, so we use the biting.
I'm a little impatient man, so I was just calculating the time. When I'm drilling, I said, "Oh, it's with 0.75 diamond will take ages for us to do."
Yeah, true. So we have a clinoid punch that we have designed many years back, and this clinoid punch is this is our design clinoid punch. So we have multiple turns, and I mean this clinoid punch is with us. So we use that to lateral bite off, and after that we use a 2 mm drill to thin it down, and then last part of it we use the 0.75 mm.
Right. If you don't mind, if you can send a picture of Kleinert punch.
Yes, of course. Maybe I can send the agent, the guy the
Yeah,
company agent who manufactures. I can.
I'm sure it will be very helpful.
Yeah. So the Kleinert punch is very fast for trauma, cystinostomies, and all. We use it, so it's very, very fast. It's safe also.
Yeah, it is better. Good. Thank you very much. Very nice.
Sure, Harsh.
Any more comments from anybody in the panel? Ahmad, are you reachable? Are you in the hospital from Afghanistan? He's on the panel. Perhaps he's in a spot where he can't speak. And anyone else have a comment before we close? Okay, thank you very much for taking the time. But I can't get over that resolution. It's so damn clear. It's it's something I spot as a non-neurosurgeon. I just said, whoa, that's different. That is high class. Okay. Now we're ending the didactic portion of the presentation, and we're kind of changing things. We're trying to get basically sponsors to help fund actually these webinars and giving the advertisers a better way to advertise, which I'll show you how it works. But we want the advertisers to be part of the conference, just like they are when we were training. They were always part of a conference with booths, but now there wasn't internet at that time. However, now they have an increasingly popular Zoom conferences. So this is a way of getting advertisers, and actually the advertising with the QR coding, which I will explain, is better for the advertiser, and you'll see as we go along. But we'll give a very brief one today. Are you there? Let's see here. Raja, are you ready? You want to give a short presentation or demo if we can?
Yeah, thank you, Dr. John.
Yeah, let me introduce Roger is from a company called sandmas.com. And Roger will talk about it. He's a representative of the company. Okay, welcome, Roger.
Yeah, we are a Sanma Medicines from Indian company. We are basically a manufacturers of surgical operating microscope as well as the exoscope. So this is one of our products.
Okay, the video is not going yet. I guess we're waiting for loading. I don't think the file is open. I know this is new for advertisers to present. As doctors, of course, it's second nature to present. But I think we have a tech problem, Roger. I think it's low bandwidth, so low bandwidth don't play videos well. Okay, Raja? Can you hear me, Raja?
What Dr. Joe?
Yeah, the video's not going, Raja. I think we're going to have to wait until you have good bandwidth. So we introduce you, but we'll do it again in a couple of days, okay?
Yeah.
And maybe we'll do a practice one, you and me. I realize this is all new for advertisers, I understand. So we're going to wrap this up. I have another conference, Raja, but thank you for coming. And thanks everybody else for coming and trying to establish a new platform for Zoom. Adios. And Takashi, we'll see you at the next webcast. We have a webcast. Yeah, I'm gonna bump you off here.
Okay.
Raja, I'm gonna bump
11
you off
o'clock.
here.
Okay,
One-
guys. Thank you. See you guys.
Thank you. Thank you.
Thank
Ike,
you.
thank
Bye bye.
you.
Thank you.
Thank you, Ike.
Thank you. Bye bye.
Bye bye bye.
Bye.
Okay, we're off, yeah, we're off YouTube. But there's a good conference coming up, Harshad. Brazil, skull-based neurosurgeon from University of Pittsburgh and from Brazil.
When it is right.
Yeah, that's six presentations
Okay.
from them. It's in about an hour and a half.
Okay.
You'll
We'll
be
join you
getting-
there.
Yeah, okay, we'll see you there. And Takashi's
Okay.
gonna moderate. Okay,
Okay.
Takashi.
Oh wow.
Okay.
The only,
Well-
see, he's got the background and everything. He's demanding a
Yes.
paycheck.
Yeah.
Okay.
He's already demanding a paycheck, Harshad. I don't know.
Yeah.
Okay. Flash meeting.
Okay.
Okay,
Ciao, bye.
okay, Takashi.
Yeah.
We'll see you there. The only
you there.
person you're gonna have to introduce is Marco Wagner. I sent
Marcus
you his,
Wagner.
yeah,
Marcus Wagner.
I sent you his Facebook profile.
Okay. Okay. So
Did you
I
get
got
that?
a
Did
face.
you get that?
Yeah, I got it. I got it. So
Yeah,
I
just
prepare.
Marcus, just explain,
1 hour and
explain
a
him like
half.
like a neurosurgeon introduces another neurosurgeon. That's all you do.
Okay. Okay.
And I'll introduce you to start. Say that
Okay.
a new recruit, a rookie,
Good.
a rookie.
Okay. And
You know how to
thank you. So if you have time, so please let me show several neurosurgical TV. So I try to make several pictures.
Oh, okay. You want to
Yeah,
do that
Japan.
now?
Yes.
What do you want to do? You're gonna
Try it.
you're gonna
Yeah.
okay. I'll let you work on that.
Yeah, I will let you let them work on that.
Okay,
I work on
okay,
it.
Raja. Thank you for coming,
Thank you.
and we'll talk to you
thank you,
soon,
Mr.
Raja.
John.
Okay, we'll
Thank you.
talk to you soon. Okay.
Thank you.
Sure.